Hello everyone. Today we are going to talk about androgens and anti-androgens. Androgens include testosterone. This will be our first topic. Second topic will be about anti-androgens. Then we are going to talk about drug therapy of erectile dysfunction. In the same way, we are also going to talk about drug therapy of benign prostatic hyperplasia and also drug therapy of cancer of prostate. So let us start with testosterone. Hypothalamus secretes gonadotropin releasing hormones. These act on pituitary, resulting in LH and FSH. These LH and FSH act on testis. Leydig cells are responsible for secretion of testosterone, whereas spermatogenesis. These two are the important actions of LH and FSH. Now, under this background, let us start about testosterone. Testosterone is male sexual hormone or an androgen. Usually, whenever testosterone is produced, it must get converted into dihydrotestosterone. For this, we need 5-alpha reductase enzyme. In the same way, this dihydrotestosterone is physiologically active and is responsible for majority of your actions in the male. They primarily include development of secondary sexual characters like deepening of voice, your male pattern baldness, appropriate growth, development of external genitalia and all. Then it is also responsible for hair growth, and then it is also responsible for your bone calcium deposition and muscle growth, and also in the bone marrow it is responsible for erythropoiesis. These two come under androgenic actions and these come under anabolic actions. Testosterone has 1:1 effect of androgens and anabolic actions. How do all these actions happen? That is mechanism of action. Whenever testosterone is secreted, this testosterone gets converted into, binds to sex hormone binding globulin, gets converted into dihydrotestosterone, and travels in blood. It reaches our target organ. After reaching target organ, target cell, the intracytoplasmic receptors of testosterone, they bind to DHT. This DHT and the steroid receptors, which are primarily intracytoplasmic. This you have to remember. These are intracytoplasmic receptors. Clear? This DHT and intracytoplasmic receptors get internalized, that is, they enter into the nucleus. In the nucleus, they bind to response elements and cause necessary changes. That is, your transcription and translation happens so that your secondary sexual characters come out. Now, this is about testosterone. So, where do you use testosterone as such? Testosterone is primarily more of a physiological role and less of a, we don't use that often, mainly because of, most importantly, when given orally, it has high first pass metabolism, because of which we prefer parenteral, mainly intramuscular, and whenever it is present in the blood, it is transported using sex hormone binding globulin. And what are the various preparations? See, let us not go into preparations per se. Only the what I want you to remember is orally active preparation of testosterone is methyl testosterone. Methyl testosterone. See, and what are the uses of testosterone per se? Most importantly, testosterone is used for primary gonadal failure. Second is senile osteoporosis in male. Obviously, whatever is the osteoporosis, treatment of choice is bisphosphonates, but we can use testosterone in the case of male senile osteoporosis, and then we can also use for the treatment of wasting, cachexia. This wasting can be either because of HIV or because of cancer. In the same way, some cases of idiopathic male infertility. See, we don't use it for that reason usually, but idiopathic male infertility. Now, what are the adverse effects? Most important adverse effect is stunted growth, because it reduces the growth, mainly because it causes early fusion of epiphysis. Second one, obviously hepatotoxic, causes cholestatic jaundice. I'm not talking about your naturally available, whatever we are trying to supplement, all those cause cholestatic jaundice. And then third one, it increases LDL and reduces HDL, so it increases the risk of MI. With this background, I think we have finished testosterone. Yes? Now we will talk about anti-androgens. Let us talk about physio. Same physio again. Testosterone After releasing under the influence of enzyme 5-alpha reductase, it's converted into dihydrotestosterone, which is the active form of it. And this acts on testosterone receptors. So, anti-androgens are primarily either 5-alpha reductase inhibitors or testosterone receptor blockers. These are primarily used. There are many others like your spironolactone, which is primarily a potassium sparing diuretic, but it also has anti-androgenic action. In the same way, there is ketoconazole, which is also anti-androgenic and which is an antifungal, but also has anti-androgenic action. Okay, so we will talk more about 5-alpha reductase inhibitors and testosterone receptor blockers here. So, 5-alpha reductase inhibitors, they mainly include finasteride and dutasteride. Second one is testosterone receptor blockers. They include flutamide and decalutamide. See, these are direct. Previously, we saw positive and negative loop feedback mechanisms. Yes, the long loop and short loop feedback mechanisms. So, whenever we give GnRH agonists, they also act as anti-androgen. So, GnRH agonists, let us not talk agonists, we'll call them as analogs, leuprolide. Yes, so these are primarily are anti-androgens. Now, where are they used? Let us start with 5-alpha reductase inhibitors. They are primarily used in the treatment of finasteride and dutasteride. They are primarily used in the treatment of benign prostatic hypertrophy, whereas your testosterone receptor blockers are primarily used in the management of flutamide, decalutamide, are primarily used in the management of combined androgenic blockade of CA prostate. Okay, so what are the usual adverse effects of these drugs? Adverse effects primarily include, first thing is, obviously they are hepatotoxic. They cause reduced reduced libido. Here we are talking about males who are already exposed to, who have crossed, they're old, they have MBBS, they're exposed. So reduced libido, though it appears serious in young, here I don't think it carries that much of importance. In the same way, they cause gynecomastia too. Clear? Now, with this, I think we have finished our anti-androgens. Now we'll talk about drug therapy of erectile dysfunction. ED. Erectile dysfunction, there are very few drugs which you need to remember. One include androgens, obviously your testosterone, where we don't use it that often these days. And then PDE5 inhibitors, mainly sildenafil, tadalafil, and then we use 5 therapy, that is your papaverine plus phentolamine regimen. And finally, we have alprostadil. Alprostadil is PGE1 analog. All these can be used in the management of erectile dysfunction. Here, we need to talk only about sildenafil group. What do PDE5 inhibitors do is, they increase cyclic AMP concentration, resulting in vasodilation. So, erection happens for longer durations and the erection happens, clear. And one major problem with them is hypotension. So, this is the most important adverse effect. So, these drugs are contraindicated in use along with nitrates, because when that is a patient who is on nitrates for any reason, for angina, usually should not take any sort of PDE5 inhibitors. Clear? What happens if they take? It results in dangerous hypotension. Fine. With this, we have finished erectile dysfunction too. Now, let us talk about benign prostatic hypertrophy. BPH. See, this is my bladder. This is the patient's bladder. This is your ureter. Prostate. It has an internal ureter wall. Bladder, prostate, and internal ureteral wall. What happens is, in a male who has crossed in their old age, prostate size increases as well as your wall, your IUP becomes spastic. Because of these two, there will be voiding difficulties. To overcome this, this is called as benign prostatic hypertrophy, where we don't have any, there is no cancer component to it. It is only your prostate size increase. And so there are two components in this BPH. One is your static component. The other one is dynamic component. Static component is increase the prostate size. To oppose this, what we usually do is we make the patient deprive from their testosterone. How do we do that? Active form of testosterone is dihydrotestosterone. So to convert, for that conversion you need 5-alpha reductase enzyme. So 5-alpha reductase inhibitors like your finasteride and dutasteride are used, so that DHT is not formed. When DHT is not there, further increase of prostate will not happen. Now let us talk about dynamic component, that is increased tonicity of internal urethral wall. This can be handled by alpha 1A antagonists. Most specific antagonists, that is urethral alpha blockers, mainly include tamsulosin, terazosin. So, a combination of tamsulosin or terazosin with finasteride or dutasteride is used in the treatment of BPH. Am I clear with this? Now, here I want you to understand the synergistic combination. Let us say this is how my prostate is increasing when there is no drug present. Okay, when only finasteride is present, it increases. The growth of prostate is not. Let us talk. With this, we have finished our benign prostatic hypertrophy also. Now, we will talk about drug therapy, benign prostatic hypertrophy also. Now, we will talk about carcinoma prostate. See, cancer prostate is a cancer which responds to your hormones. So, cancer prostate. Yes, obviously surgical treatment, radiation therapy will be there. But with respect to chemotherapy, cancer prostate is handled by combined androgenic blockade. What I mean by this combined androgenic blockade is we use your anti-androgens, mainly your testosterone receptor blockers, like your flutamide and bicalutamide, plus obviously your leuprolide group of drugs, that is your GnRH agonist, so that your testosterone is almost absent in the patient, because of which he will have a complete, he will not have an issue. Obviously, treatment of choice is your orchidectomy and resection. Okay, but this is how. And then we forgot to mention one small topic here that includes androgenic alopecia or your male patterned baldness, where treatment of choice is obviously minoxidil. We will write about it also, the small topic. Male patterned baldness or male patterned baldness. Obviously, treatment, there are multiple modalities. One such is minoxidil, topically given. What is minoxidil? It's a potassium channel modulator. Mainly it causes your anaphasic growth, hair growth, and then obviously anti-androgens, mainly 5-alpha reductase inhibitors like your finasteride. When these two are given together, usually there is an answer for this male pattern baldness. Thank you for patient listening.